Welcome to Public Health Ideas. I'm Sandro Galea. I serve as Dean of School of Public Health at Washington University. These are conversations that aim to highlight work in public health that advances the science of health. Today, I have the privilege of speaking with Professor Morgan Shields. Dr. Shields is an assistant professor at the Washington University Brown School of Social Work. We're going to be discussing two papers: her paper in Psychiatric Services, Institutional Betrayal in Inpatient Psychiatry, Effects on Trust and Engagement with Care, and her paper in Health Affairs Scholar, Patient-Centered Inpatient Psychiatry is associated with outcomes, ownership, and national quality measures. Professor Shields, thank you for joining us.
Thank you so much for having me, and thank you for reading our work.
So let's start with your paper, Institutional Betrayal in Inpatient Psychiatry. Tell us a little bit about what led to this work, how did the study come about, and what were the key questions behind it?
Okay, so, there are many ways one could answer this question. But first I'll just start with conceptually. Conceptually, we can think of inpatient psychiatric care as being characterized as extreme power imbalances between patients and really all other actors. So between providers, payers, regulators, sometimes family. And patients are really they're the ones who bear all of the costs. It's their body, their minds, and they have the least power. And so there's actually, an injustice there. And I view these power imbalances as being a fundamental driver of poor quality of care for people with mental health conditions. So there's that conceptual sort of foundation of understanding. And then in my work, where I've interviewed and done focus groups with people who have lived experience of inpatient psychiatric care, overwhelmingly they describe experiences that are not just low quality of care where they've had bad food or it wasn't quick enough or what have you, but actually dehumanizing experiences. They've experienced abuse and profound. And so I've come to realize that actually the floor for care quality when it comes to inpatient psychiatric care is very low and perhaps lower than other healthcare settings. So there's that. And then since the 1950s, researchers have been trying to produce evidence for the utility of inpatient psychiatric care for population health, and they have failed to do so. So we actually don't have any evidence to suggest that inpatient psychiatric care is more beneficial for people experiencing all kinds of crises relative to alternatives, intensive outpatient treatment. And that's really curious, right? Because it's ubiquitously used. It's sort of a staple in our system. And in fact, the risk for suicide is extraordinarily high following discharge from inpatient psychiatry, and only 50% of people have a follow-up appointment post-discharge. And so, there's many mechanisms, right, that might explain poor outcomes and iatrogenic harm of the hospital. And what I've really focused on is the experience of the care itself as a meaningful mechanism that should be studied. And so that's sort of the basis of the motivation behind this project, because believe it or not, nobody has demonstrated that at least quantitatively, experiences of inpatient psychiatric care are associated with changes in trust and willingness to engage in post-discharge care. It sounds intuitive that there would be these associations, but no one has produced empirical evidence for that. And so that was a primary motivator for this study.
Tell us a little bit about what you mean by institutional betrayal.
So the concept of institutional betrayal actually comes from betrayal trauma theory, which was proposed by Professor Jennifer Freed, and she's produced evidence to support her theory. And betrayal trauma theory is really at the individual level. And that suggests that when you're in a relationship with someone where there's power imbalance and there's vulnerability, where you are dependent upon this other person, when they do harm, when they betray you, that the psychological consequences are more severe, that it serves as a moderator, the vulnerability of the relationship and the extent to which you trust and depend on the other person. Institutional betrayal builds on that theory and applies that concept to the institutional level. So it's essentially when an institution fails to protect a person, especially if they have cultures or structures that create environments where harm is more likely, or when they fail to respond to harm. And so this institutional betrayal actually was sort of famously applied to the context of USA gymnastics. So the gymnasts were sexually abused by one of the providers, and USA Gymnastics did not prevent it, and they did not appropriately respond. And so that's sort of a famous example of institutional betrayal. And we can imagine in the setting of inpatient psychiatry, I describe power imbalance and vulnerability of patients. It fits really nicely within the framework of institutional betrayal. And so that's why, we decided to use Professor Freed's concept of institutional betrayal, because it fits quite nicely for this context.
Tell us a little bit about, so you surveyed former psychiatric patients. Tell us about questions asked, what the analysis was, and what it showed.
So we did an online survey where we recruited people who had experienced inpatient psychiatric care, in part because it's actually almost impossible to recruit people systematically from hospitals in any sort of systematic fashion if you don't have the federal government involved in sort of collecting that data systematically. So this was sort of the best we could do, is to just recruit from the community people who had experience. And so Professor Freed has a checklist measure of institutional betrayal. And so we used that. We also included a measure of patient-centered care, which was this other paper that we published. And we asked people to self-report the extent to which their hospital experience reduced their trust in mental health providers, the extent to which their experience reduced their willingness to disclose distressing thoughts to a mental health provider, the extent to which the experience reduced their willingness to go to the hospital on a voluntary basis, and whether or not they had a 30-day follow-up visit. And I wanted to ask that in part because our current accountability measures are focused on follow-up care and engagement in care. So if one can show that how you treat a person matters in terms of their engagement with care, then maybe that might motivate sort of interest in improving care experiences. So that was one of the reasons for that. And then we also, so a concern here is, a person who might just have a negative disposition might just say, awful experience, no try, yes, awful, and sort of respond negatively across the board. And so I was trying to figure out how to get at that, or to control for disposition or baseline trust in care. So we did ask, before you were admitted, to what extent did you trust that you would receive high quality, safe, dignified care? And then we controlled for that in our models as a way to try to get at disposition and expectations that might be correlated with everything.
So what did you end up finding? Like, what is driving the institutional betrayal, or the report perception of institutional betrayal?
Okay. Well, first I want to back up and say, I'm not sure this one study can explain all of the drivers of institutional betrayal. Because it's at multiple levels. I could sort of describe all of these factors that I think are at play. We were really only able to measure patient level factors, characteristics, their demographics, some clinical characteristics. And then actually, we did ask people to share the name of the hospital, the location of the hospital, and then we cleaned those data and we linked it to secondary data so we can describe characteristics of the hospital. Mm-hmm. So when we were able to do that for over half of the sample, and that included ownership, so for-profit, nonprofit, government. And the only characteristics that were associated with actually reporting institutional betrayal were age and then ownership. So people who were hospitalized at a for-profit hospital were much more likely to report experiencing institutional betrayal relative to those who were hospitalized at a nonprofit, which is interesting. Mm-hmm. Other patient characteristics were not significant. We don't exactly know why. I mean, there's limitations to the study, so we can't necessarily rule out that other patient characteristics are not somehow associated with experiencing betrayal, but this is what we found in our one study.
So I was going to ask you about the for-profit.
Okay, yes.
So that was interesting. Obviously, there's only so much you can infer from the study, but what are your thoughts? Like, why is that?
Why do people experience betrayal?
Yeah, more in for-profit versus not-for-profit.
More in for-profit versus not-profit specifically. Well, so one way to think about power imbalance is through an economics framework of market failures. And so in the United States, at least, most of inpatient psychiatric care is provided through a market. Most providers are private. We have private payers. Even Medicaid and Medicare has, managed care organizations. And so it's market-based, but there are huge market failures. And we know this across all of healthcare. I mean, patients do not have access to information about care quality or complete information, and they don't necessarily have the agency to act on that information, even if they did. These market failures are more extreme in emergency situations because there's more constraints on your ability to shop. And you can imagine with inpatient psychiatric care, it's even more extreme. I mean, just one unique characteristic of inpatient psych is the use of involuntary admission. We don't use that in any other area of healthcare. If someone has cancer and they refuse chemo, we don't force it, right, for example. And so that's a unique constraint on choice, structurally. And then if you layer on that families can't easily be at the bedside to serve as advocates like they can in other settings, that patients' perceptions of reality are totally discounted, they are especially vulnerable. And so in situations like this, where there are extreme market failures, we theoretically would expect for-profits to exploit those market failures to maximize profits. How might they do that? They might hire unqualified staff. They might have minimum staffing. They may inappropriately hospitalize a person, et cetera, et cetera. So we hypothesize that actually people hospitalized at a for-profit would experience greater institutional betrayal for all those reasons, because everything's sort of set up against them, and they're very vulnerable to exploitation.
That's a nice bridge to the other paper. So let me just ask you a couple questions about the other papers. You talk about sort of patient-centered inpatient psychiatry, and you talk about in this paper that psychiatric patients' reports of patient-centered care are associated with changes in trust.
Yes.
In which intuitively makes sense, right? Intuitively makes sense. So tell us a little bit, lead us through patient-centered care, how it may support trust. And I'm also intrigued about the bridge between the two papers, right? Because we're talking about betrayal, we're talking about the absence of trust.
Well, first of all, yes. So patient-centered care is, you can actually think of it as almost the inverse of institutional betrayal. I mean, they are distinct. They're not concepts. They're not perfectly correlated, but they're very strongly inversely correlated. Patient-centered care is care that is respectful, treats a person with dignity and autonomy, and is personalized. I mean, it's sort of a big concept. So, and in mental health care especially, we could argue all of healthcare. This is really important for building rapport and trust. And when someone's in a mental health crisis especially, I'll give an example of psychosis. Fundamentally, they're scared. I mean, most people in psychosis are really terrified. They may not trust you. And part of that could be due to their clinical condition, but also due to past experiences. And so it seems even more salient and important to really prioritize treating them with respect, giving them as much choice as possible, really building that trust in order to foster engagement. I mean, it's an important outcome in and of itself if we value dignity and respect on its own, but it also can be associated with the patient feeling like they can disclose and be honest with you, and that they're not going to be punished, and that it's worthwhile to engage in a relationship with you and long term. So yes, you can kind of think of patient-centered care as sort of in some ways the inverse of institutional betrayal, and they both are associated with outcomes of trust and willingness to engage in care, but just in the opposite direction.
What would be policies that can actually be implemented to promote patient-centered care in psychiatric settings?
This is a great question. So I'm going to answer this in two parts. So the first part is assuming we want to reform the hospital and make the hospital better. Mm-hmm. Okay. Well, first of all, we need improved data. And this is sort of the main thing that I try to become almost an advocate for improved data, in part because it's challenging to do research on this when we don't have better data. So one thing that the federal government can do, which they have done, and I'm excited about this, is to implement a patient experience measure within their quality reporting program. It's called the Inpatient Psychiatric Facility Quality Reporting Program. It's the IPFQR. Psych patients, before recently, were the only patient population systematically excluded from patient experience measurement. They are the only ones excluded from the HCAHPS, and CMS has their own special program for inpatient psych, and they were not measuring patient experience. So that's changing. And so I think the more that we can innovate around different forms of patient experience measurement, and think about that and patient-reported outcomes and build up that infrastructure, that in and of itself not only supports research, but broader scrutiny, and also forms as sort of a way of orienting providers around this as being a priority for regulators and for payers. So that's one thing. And the other is the regulations to better reflect the value of patient-centered care. I mean, unfortunately, our regulations, the way we conceptualize care quality is a reflection of our values. And so are then our regulations and standards. Right now, they are very anchored around safety. And so when you have everything anchored around safety, physical safety, you end up having a system that is very risk averse, that is very quick to contain a person, sometimes through physical means, and doesn't appropriately value relationships and that interpersonal aspect. So the extent to which our accountability mechanisms can just prioritize patient-centered care in all of its ways, data, regulations, standards, that would be a huge step forward. And there are, evidence-based models, like the 6 core strategies, for example, or the sanctuary model, which could be implemented within inpatient psychiatric care, if that was the expectation systematically for hospitals to implement this. The other thing I'll say is, back in the 80s, the federal government created PAMI, which mandated these protection and advocacy agencies, which are usually law firms, to exist in every single state. And their original charge was to advocate for institutionalized people who had mental illness. They are funded by the federal government, and they have unique access to psychiatric hospitals, including state-owned hospitals. The reason they're funded by the feds is to keep it separated from the states, because you can imagine the states might struggle with self-scrutiny, if that makes sense. And so they actually can go into these hospitals and they can have an office there, and their whole objective is to advocate for patients and to sort of serve as a watchdog. Their funding has been slashed, they've sort of become quite politicized, and so I think that's a creative mechanism, right? We can think about how to improve observability of these facilities, and have more advocates inside of these facilities, including peer support. Those are creative solutions that have promise. How it gets implemented, those are empirical questions. But my final point is, a lot of people that I interview in my research they've been so harmed by the hospital. They don't think it's a good thing in general at all. And they're very wary of researchers like myself who are sort of focused on reform of the hospital and not thinking about alternatives. And there are a variety of alternative models for crisis response. And so we might want to also think about creative approaches to supporting people in crisis and building up these alternative models that are viable. They have evidence, but they haven't really been widely implemented. We're really it seems really dependent on the emergency department and the hospital in this country, it seems, currently. And that could be different if we thought more creatively about alternatives.
So what's your next step in this work?
So I'm very excited. I'm currently, so we looked at trust as an outcome. I made it up. I made up the question about trust. It's an intuitive question. I think it's valid on its face. But in that process, I realized there aren't any measures of trust that are specific to crisis services. And this is a very unique context. And most of these measures of trust are related to primary care. And so we have developed a measure of trust in crisis services, which is supposed to be a flexible measure that could be used not just for the hospital, but think more broadly about the alternatives, for example, so we can compare people's beliefs in the trustworthiness of these different settings, et cetera. And my thinking here is, if we have a measure, then we can think about prioritizing that as an outcome, right, to then incentivize patient-centered care. So we're in the process of trying to validate that measure, and then I would like to create sort of a toolkit for organizations and policymakers to evaluate the trustworthiness of their services. And so that's the most immediate next step. And then also those tools can be used to ask a variety of questions.
Well, I look forward to reading about that.
Thank you so much. Thank you for taking the time.
Thank you for the work you're doing.
Thank you.
Thank you, everybody.